All right. So, hello, everyone. Welcome back to Legacy Running. I am so excited for today's episode. We are joined by Dr. Gary Chimes. He is a physiatrist in Bellevue, Washington at Lake Washington Sport and Spine. Hi, Dr. Chimes. How are you doing today?
Hey, it's great to see you, Sarah. Thanks for having me on.
So excited to have you. I feel like you are going to be a really popular guest on the show because you have so much knowledge and wisdom about women runners with hip pain.
Absolutely. And I'm trying to keep track. How long have you and I known each other? It feels like has it been about 6, 7 years?
Actually a little bit less. I started practicing in Kirkland in 2019.
Okay.
So really not too long.
Okay. Yeah, but I think I've been working with you pretty much since you moved to the area, and it's
Yeah.
really been a great relationship to have.
Yeah, you're a wonderful clinician. And I always joke that I send all of my tough cases to you.
Yeah.
Can you go ahead and just tell us a little bit about yourself? You can go personally and then also professionally, like what you do, your practice, and kind of explain what physiatry is. I don't think a lot of people know really what that is.
Sure. So personally, I'm a 50-year-old guy, originally from New Jersey, live in Redmond now, married, have 2 young boys. My background athletically is my primary sport was swimming. I liked wrestling better, but I was kind of a pudgy kid, and in a weight restricted sport, that's not a great characteristic. And then in college, I was a club level triathlete at University of Wisconsin. My areas of like athletic interest tend to be in triathlon, running, swimming, martial arts. Those are probably like my primary sports interests, but I see athletes of all types. And then I think one of the things probably relevant for some of what you do, I have a twin sister. So my PhD was in sports biomechanics, particularly looking at female overhand throwing athletes, but a lot of my focus has been on sex differences. So men and women are different. They have differences in terms of biomechanics, in terms of hormones, and those differences manifest certain ways in younger people. Like young women might have issues with relative energy deficit syndrome. Then you have older age ranges where you might be dealing with things like pelvic floor insufficiency or menopausal issues.
Yeah.
So I think part of being a good musculoskeletal physician is to know how are men and women differently, especially over the different phases of the life cycle. And then in terms of the type of physician, so went to college. I was a double major in math and zoology. Did a combined MD PhD program at Stony Brook in Long Island. Then did internship and residency in physical medicine and rehabilitation, which is sometimes called physiatry or physiatry. And then I did a sports medicine fellowship at Northwestern. And then I was in academia for a while. I ran the Spine Center at the University of Arkansas, ran the Musculoskeletal Sports and Spine Fellowship at University of Pittsburgh for 5 years. And then, I hit 40, had my midlife crisis, moved out here, joined my partner, Garrett Hyman, and I've been out here for a decade now.
Oh my gosh. I did not know that you have done all of those things. That is phenomenal.
And I think it's, useful. I think that, you probably are seeing this with your own career. I've realized that, you can have a 10, 20-year plan, but really life has like these 5-year segments, and you just learn something from each of them and hopefully bring that forward into, evolving over time.
Yeah, for sure. Yeah, I never thought I would be specifically working with women runners with hip pain, but here we are. Of all those segments, what part was your favorite? Teaching, treating?
Yeah, that's a good question. I definitely, view myself a lot as a mentor. So I know I was pretty well known nationally in academic circles, and a lot of people were surprised when I left academia because I had a really strong reputation for educating residents and fellows. But for example, one of my current medical assistant was her last day yesterday, and she's moving on to medical school. So
Cool.
And I just think getting to be part of her, a mentor to her in her journey into becoming a physician has been really valuable. My first medical assistant out here is now a physical therapist in the community. So getting to be part of his journey. I have another resident, another former medical assistant of mine who's now an orthopedic surgery resident. So I think that I like mentoring, and I think that for me as a physician, that's a lot of what I value the most. So the relationship, like I had like a really good moment kind of early in the pandemic where there's a patient of mine who's a really bright guy. He's done very well in tech, and he just had me over his house. We were talking, and he definitely found the advice I was giving him about musculoskeletal medicine helpful. But he's like, he actually gave me some really good life advice. You know,
Mm,
in the process of working on a book about being middle aged, and I think that I I find the relationships the most satisfying when people find that the guidance I'm giving them is helping empower them making better decisions about how to manage their own life, whether
mhm.
learning to run a marathon, or it's how do they negotiate the death of their parent while they're trying to meet all their health responsibilities. I find that very satisfying.
That's awesome. Yeah, there's like a mentoring component in both being a resident fellow mentor and then just guiding patients as well.
Yeah.
I would love to get into talking about labral tears and FAI. Now, I would say a huge reason that I started my like specific practice is that I was finding women ages like 25 to 50 developing labral tears and or FAI, or them coming to fruition for those people, and just having so much discrepancy and different treatment options available to them. So I would love to just hear like what it looks like for you to kind of diagnose and then treat a, let's say, active gal that comes in with hip pain.
Sure. And I'll be curious because I'm wondering if we even, one of the things I like about working with physical therapists is that I think that we have adjacent, non-overlapping skill sets. So I'm curious if we end up, diagnosing FAI the same way. But, I always like to work from a chief complaint outward. And one of
Yeah.
the things I always try to encourage patients to do is to separate their symptom from their hypothesis. So,
Yes.
it's fairly common as someone come in saying, I have hip pain from FAI. And
Yep.
we want to know, like, can you point where it hurts? So even just with the term hip in doctor English and hip in human English may not mean the same thing. So
Yeah.
when I hear the term hip, I'm thinking of the femoroacetabular joint, which is really in the front.
Yep.
As opposed to like I'd say even most of the time when I have people coming in with quote unquote hip pain, they're pointing at the outside of their pelvis, which might be like their trochanteric region, or
Yep.
they're pointing at their buttock. Well, let's assume from the moment we're talking about symptoms in the front,
Yeah.
I then try to create a differential diagnosis process of what are the things that could be going on. So it can be, FAI, femoral acetabular impingement. It could be a labral injury. It could be hip osteoarthritis. It could be a hip flexor issue. When we talk about the hip flexors, it's basically four hip flexors. Most time if people are saying without qualifying, they're referring to the other psoas, but it could be their rectus femoris, it could be the tensor fascia lata, or it could be the sartorius. It could be a pelvic insufficiency fracture, which is, I think, an important one.
Yeah.
Also have to start thinking about things that are not obviously musculoskeletal. Like it can
Yep.
be a ovarian cyst. It could be a presentation of pelvic floor insufficiency. So, sometimes it's bad things like cancer. So,
Yeah.
one of the things that's important to me as a physician is like not forget that I'm a doctor and like consider the medical things that could be going on as well.
Mhm.
And then, as I'm trying to go through my process, I'm pretty extreme in how structured my visits are.
Mhm.
So when I look at both my positive and my negative reviews, it's both are referencing my insistence in structure. And I like to go through a very structured process of timing, what location is it in, which movements provoke it. I
Mhm.
spend a lot of energy on those things to try and tease out, and a lot of the questions are, just trying to rule out like a class of diagnoses.
Yeah. Yeah, I actually totally agree. I am also extremely structured in my exam, almost to the point where I have to kind of pre-warn the person, hey, today is really uh like assessment day. Like I need to gather this information. And if I kind of gauge that they are more like maybe, I don't know, emotional about it and like can't handle the full exam, then I'm like, okay, we might have to break this up into 2 days because a true exam for me with explaining diagnoses of what I find probably takes like an hour, hour and a half to really go through everything. And luckily for me, like when patients come to me, I can be more musculoskeletal minded because I mean I am a physical therapist and not like a medical doctor. But in the back of my head, I do have to do my due diligence and screen absolutely everything to ensure, okay, is this coming from the lumbar spine? Does it not have musculoskeletal components? Like, is it something like cancer that I need to send out for? Or like, is this a bone stress, injury that we need to be more concerned about? So yeah, I totally agree.
Yeah,
Um,
and to toot your horn a little bit, I think you're unusually good about recognizing scope. So I think that like you're an excellent physical therapist in doing what you do, but I also think one of the things I've admired about the way you practice is you're pretty good at recognizing I'm 90% sure I know what I'm dealing with here, but that 10% is concerning enough. Let me get somebody else to help me out with making sure I'm ruling out, is this an L3 radiculopathy coming from the back? Is this a stress fracture? I think you've been unusually good about that.
Thank you. Thanks. Yeah, I think it's important because we don't have time to waste, and I don't want anyone to go down the wrong rabbit hole with treatment. Let's say that you have suspected that someone does have a labral tear or FAI. What is your next step?
Sure. So, I would define, so like FAI and labral injuries are related. So FAI, stands for femoroacetabular impingement. So the femoro there is referring to the thigh, and we're talking about specifically the femoral head, which is the ball of the ball and socket joint. And the A is acetabular, which is the socket. So when you think about joints of the body, all joints are going to have this balance between mobility and stability. And some joints, like your shoulder, are very mobile but not stable. So the femoral acetabular joint is the most extreme joint in the body in the sense that it is very stable but is not very mobile.
Yeah.
Now, with hip morphology, there are standard shapes that a hip should have. There's some variation, but some people will have bony anatomy that will limit the amount of movement that it can have. And there's different types. So there is a cam deformity where the femoral head is deformed in a way where it normally the femoral head has like a concavity that comes off of it along the femoral neck, so that when the hip rotates, there's clearance space. And people with a cam deformity, it looks more kind of club-like, and it doesn't allow for that room. There's another subtype called a pincher, where the socket has like an overhang, and then you can have a combined form. So like, let's say I get a referral from a physical therapist, or the patient comes in and they don't have a lot of mobility. One of the things I want to know is that limitation because of soft tissue, or is it because of hard tissue?
Yeah.
Now, beyond the joint's very stable because of the shape of the socket, but the ligaments that make up the capsule of the hip are also the stiffest ligaments in the body. In particular, there's a ligament in the front called the ligament of Bigelow, or the iliofemoral ligament, and it's an unusually stiff ligament. So let's say somebody's having like some restrictions related to ligaments, that's something that you can work on and over time get greater mobility. But if there's like a piece of bone that's like in the way, there's going to be an upper limit to how much you can mobilize it.
Yeah.
Now, let's say you have somebody who has femoral acetabular impingement. One of the problems is that you have bones rubbing on things that you may not want it to. And it can have a couple of different forms. There are two types of cartilage within the joint. There is a hard, smooth cartilage on the end of the bone called hyaline cartilage. And it is very similar to like the surface of an iPhone. It's hard and smooth, and it's designed for handling a lot of load. Osteoarthritis has a few different forms, but a lot of what we think of osteoarthritis, which is also known as the germ joint disease, is related to injury to that hyaline cartilage. And then they have a second type of cartilage called the labrum. And the labrum is what's called a fibrocartilage. It's rubbery, kind of like the earlobe, and it helps to maintain a suction to keep the hip well in the socket. So in particular, one of the things that we are concerned about is that if somebody has FAI, femoral acetabular impingement, and they're grinding tissue, what are they grinding? And one of the structures that we're in particular concerned about is grinding of the labrum. And one of the things that's, one of the reasons that this is an area where it's really important to have like excellent physical therapists, especially ones who specialize on it, is a lot of the treatments for FAI and labral tears haven't been great historically. So for example, for surgery, there are surgeries for it, but it's still amongst the lower success surgeries that happens in orthopedics.
Yeah.
So, it's an option, but it's not a home run option. So
Yeah.
having non-operative options like physical therapy can make an enormous difference.
Yeah, yeah, that is definitely for sure. I would say, I remember seeing my first labral tear as a new grad, and I was like, I have no idea what to do. We did not learn this in school, and it took a lot of mentoring to get there, and to learn like what are good options when someone is either pre-surgical and post-surgical. And I would say yeah, it's been a hard line to learn, or hard line to walk, and to learn how to like actually get patients better with this.
Yeah, so if I can circle back onto diagnosis a bit for a moment. So a lot
Yeah.
of it comes down to imaging. So for imaging, one of the things is X-rays can be quite helpful. This is one. A lot of times, like when people order X-rays in the musculoskeletal world, they're doing it as a hoop to jump through for insurance purposes, so they can get an MRI. This is one of the circumstances where the X-ray is genuinely useful. There's a type of image called the standard AP that's standing, and that gives us some information about the shape of the hip. It doesn't really directly visualize the labrum. I do a lot of musculoskeletal ultrasound in office, which can be quite wonderful. If I see a labral tear on ultrasound, it's a meaningful finding, but part of the labrum is deep inside, and ultrasound's better than MRI for detail on superficial structures like hip flexors, but it's not as good for the labrum. And then there's the MRI where you're using a magnet to take a picture. A regular MRI is actually not a great fit for looking at the labrum, because sometimes when you have a tear of the labrum, because the labrum is like hugging the head of the femur, you don't see it. So we do a variation on the MRI called an MR arthrogram, where we first inject contrast into the joint and then do the MRI. And that serves two purposes. One is it just lets you see out the labrum. The other thing, something that I do, not everybody does, I think most people don't do, is I always also ask that they put numbing agent into the joint. The reason that's really valuable is that just because someone has a labral tear, that doesn't mean what's actually causing their symptoms. So, somebody who has an MR arthrogram, there's numbing agent in the joint. If they have the labral tear, but the numbing agent makes no difference on their symptoms, that makes me a little bit skeptical that the labrum is even the source of the symptoms.
Yeah.
Yeah. And I just would also make this caveat, because this might be really helpful for the patients of yours. I definitely have had people who try to kind of triage their own care, or maybe have like pressure their primary care doctor into ordering an MRI for them, and they often get the wrong sequence.
Mm.
So there's the nuances about, for example, using lidocaine in the arthrogram. There's also there's an MRI of the pelvis and MRI of the hip aren't the same image.
Yeah.
And then there's also other sequences, like if I'm concerned about like a core muscle injury or sports hernia, I might order some special sequences. If I'm concerned about piriformis, I might order special sequences. So part of the reason to see a sports medicine specialist like myself, rather than just getting an MRI from your primary care doctor, is they might order the wrong sequence.
Yeah, that's huge. I actually, um, yeah, I didn't really think about the sequencing aspect of that, but the numbing agent with the MRI is huge. The literature has largely shown that if you experience like a significant amount of relief from the numbing agent as it's injected into the joint, then that is what is shown to have better results with surgery. For the surgery, that's still kind of like a wash if it's going to be super effective or not. So that's awesome that you do that.
Yeah, like if any treatment, whether we're talking about physical therapy, injections, surgery, let's say I have a patient who doesn't get better, I always want to ask, two of the questions I'll ask: did it not work because we had the wrong diagnosis, or did it not work because we had the correct diagnosis, but the treatment, wasn't appropriate?
Yeah.
But a significant number of people, I've had many people who had labral surgery, didn't get better. And ultimately, we start to suspect it was the labral wasn't the problem in the first place.
Yeah. Yeah. Can you speak on maybe if it's not the labrum, like it's like, let's say I have a labral tear, clear as day, it's right there. That's really not my pain driver. What are other things in the area that could be driving the pain?
Sure. So let's say, you do the intra-articular injection, meaning within the joint. What are the structures that are within the joint? So the labrum is one of the structures. The hyaline cartilage is another structure, which is like the hard, smooth cartilage of the joint. There's a ligament called the ligamentum teres, and then there's the capsule itself. So those are basically the four things that are getting numbed by the joint, and those are intra-articular. What is extra-articular? So the examples of things that would be extra-articular would be the hip flexor tendons. I think in the literature, you'll see people refer to the iliopsoas as the most commonly affected of the hip flexors. I think the proximal rectus femoris, which is another of the hip flexors, is at least as common. And I think that that's something where musculoskeletal ultrasound has been really helpful to look at it, because I think those are getting missed on MRI a lot. But it could be any of the hip flexors. You could be having issues with like the pubic bone region. So you can have, there's different terms for like osteitis pubis. There's a muscle injury, especially anybody who's doing like lateral cutting sports like soccer or ultimate frisbee. That's something that you want to consider. And then we talked about things that are like gynecologic in nature. So people have like ovarian cysts would be another possibility. And then the back is another important one. So like upper lumbar herniated disc or radiculopathy could, and then I guess pelvic floor would be another big one.
Yeah, that's huge. I would say in my practice, those are the biggest ones that I've noticed is like upper lumbar, L2, L3 region, the adductor groups, tendon problems with those, and then pelvic floor as well. If someone is experiencing a labral tear, I'll find that a lot of the muscles like the hip flexors, adductors, pelvic floor are commonly like on guard and become over like
Absolutely. That's a great point. Like I think, for example, a lot of people will put a lot of weight in as like, hey, I've been using a lacrosse ball and rubbing over my psoas and it's tender. And I'll tell you, it's rare that you have any people who aren't tender when you're massaging earlier. So it can, just go to the other side, probably is a little bit tender as well. But B, if you're having tenderness in your hip flexor, that might be guarding the structures that are underneath it. And I think, go ahead.
Which can be pretty painful in and of itself. That guarding is like, it's not comfortable.
Yeah, and I think an important concept to recognize with the hip, there's a concept of somatotopic resolution. So resolution, if you think about like a photograph, is how close can 2 points be to one another and be able to distinguish that they're separate points. So somatotopic resolution is like how precisely are you able to get feedback from a region. And the hip, even though it's such a large area, the density of pain fibers in the area is actually quite small. Like the tip of your thumb has more pain receptors than your whole pelvic region does. So I think people, when they have like intuitions about pain, like if you have a splinter in your thumb, you can localize exactly where it is. But the ability to distinguish between like the proximal rectus femoris tendon from your iliopsoas tendon, even though they're only like 2 centimeters apart, the ability to distinguish them is not that high. And I think one of the things that's really challenging with the hip is that people often don't have great intuition around the region, but they don't know that they don't have great intuition. Can I go on that a little bit more for a moment? Okay, because like one of the big ones I care about a lot are stress fractures, and I think they get missed a lot. And I think that there's under imaging, and most people have no idea what their pain tolerance actually is. So I find, and I'm not great at guessing. I think, back when I was in training, they used to like treat like it was a act of Congress to order an MRI, and I think we were dramatically under ordering them. And now that I order them much more liberally, I will say I'm often quite surprised, and to the point where I don't even necessarily, I order it because I know it's a possibility. But, I think there's a lot of people who are stunned to find out that they have like a huge sacral stress fracture.
Yeah, it's huge, especially in women runners as well.
Absolutely.
Hormonal aspects going into that. So I would love to talk a little bit about treatment options for people that have been diagnosed with, let's say it's a labral tear and it is a symptomatic labral tear and that's kind of their main driver. What are some of your options that you're giving your patients?
Yes, I think physical therapy is really critical. I do think finding someone like you who has experience with runners in, a demographic similar to them is useful. That might seem, well, everybody does that, but not necessarily. Like if you have a clinic that's taking care of like a lot of Medicare patients and is dealing with, basic mobility of people following a stroke, their ability to help with a 28-year-old runner is not going to be high. And I think, there's a lot of things that can be done there in terms of, just manual techniques and long axis distraction that can help with the capsule. There's the different models like the Gary Gray model or some of these other models that are trying to mobilize the, iliofemoral ligament. So I think those are things that can make a big difference. I find a lot of patients are very skeptical about it. If you've had bad experiences with that, don't write off physical therapy. It might be the specific physical therapist. I actually just think another point, like make sure your physical therapist was actually a physical therapist. So it's fairly common that someone has quote unquote physical therapy, but they're actually seeing a personal trainer, or they're seeing an athletic trainer working out of a chiropractor's office, or they're seeing a PT assistant. And if you're getting great responses, fine. But if you weren't getting great responses to PT, and it turns out you actually never worked with a physical therapist, that's important to consider. So that would be, I guess, where I usually am starting. I think that some of the things that I consider, I do a lot of guided injections. I think as a general rule, I think it's smart to start with injections before surgery because you don't have the same irreversible component. Actually, before I forget, because also you had given a case, and I might be getting specific on one of your earlier podcasts, you talked about somebody with a hip issue, went through a bunch of procedural stuff. I think they may have been having like ankle dorsiflexion issues. And so, a lot of times when people are having problems with their hip, is really downstream of other things going on in their kinetic chain. So, or maybe I reverse me, it was an ankle person, there was a hip issue. But the point being that just because your pain is coming from the hip, often correcting the mechanics in like the ankle or the knee go a long way. So you're not asking the hip to do more than it was designed to do.
Yeah, that's huge. That's a huge part of PT.
Yeah. So, one of the things I often like to do from a procedural standpoint, one of the techniques we use is a hip dilation, where we just under ultrasound guidance will direct a needle into the capsule and we'll just expand the joint with as much fluid as it can handle. Usually I can get probably about 12 milliliters of fluid in there. And what that does is it just stretches the capsule from the inside and allows the physical therapist to do more mobility than they would otherwise. And if you have somebody who has femoral acetabular impingement, which is kind of squeezing on the labrum, if you can open up that space even by like 3%, that might be enough that the labrum's not grinding anymore. So that's a good starting point for a lot of people. And then I would say the next category, one of the techniques I'm moving away from, but I'll mention it's sometimes helpful for limited circumstances, is corticosteroid. We typically use triamcinolone. So when people talk about cortisone shots, I don't like using it a lot of times because it does tend to make the hip degrade more over time. So, but it tends to be helpful in the short term. So the circumstances where I might use that is that if somebody has like a high leverage event, like they had a trip to New Zealand for 6 weeks that they had planned, and that is like a life-changing type of trip, and feeling better on that trip would make a big difference for them. I am willing to use cortisone, but I'll say just know this probably is going to make things worse in the long term. So willing to have the short-term benefit for what might be worse, in the long term. And then you get into the category of what I would call orthobiologics, some people call regenerative medicine, and that's going to be things like platelet plasma and micronized fat. And the product we use there is something called lipogems. And I can go into those more if you would like me to.
Yeah, I would love to. I think the literature now is mostly pointing away from the cortisone injections, really leaning to like one and done, like if you need it and then done, and then now turning more to like orthobiologic. So yeah, that would be awesome.
And I think the one and done, I don't think is the right answer on that either. I think like you have seen rapid progression of osteoarthritis from one. So there's nothing magic about the number of one. It's, the doing one, it also can affect like bone density as well. So A lot of times runners are going to be women who are going to be prone to osteoporosis down the road, especially, if you're a runner who has like a history of like bulimia or anorexia in the past, they might be lower bone density in the baseline. Yeah, but anyway, so with plain-rich plasma and micronized fat, the idea behind this is that your body does have some capacity for natural healing. As an aside, I have like a number of patients who are mechanical engineers, and one of the things I'll talk to them on the difference between mechanical engineering and biomechanical engineering. Because the principles of like load, creep, stress, strain, those are true whether you're dealing with like a sheet of aluminum or dealing with a hip joint. So, the reason biomechanical engineering is its own field is that the tissue has capacity for self-healing and that there's more variance in the tissue. So to me, as a physician, biomechanical engineering is the study of mechanical engineering on variable materials that have a capacity for self-healing. And the mechanism for self-healing is often going to be things that are in the blood. So your blood has three major constituents. There's going to be red blood cells, which carry oxygen, white blood cells, which fight infection, and then the platelets and the things that bind and aggregate to the platelets. Those are going to be what helps with healing. So you cut your skin, blood rushes to the area. It's mostly going to be the platelets and the things that bind the platelets that are going to help with that healing capacity. So if you have an injury like a labral injury, what you can do is you can take blood out of somebody's arm, you spin it down with a centrifuge to get the highest density of the healing factors, and then you would inject it into the joint under guidance so they can bathe the interarticular structures. So that's the idea. People often ask, like, does it heal the whole thing? Does it get it back to a pristine state? And it does not. What it probably is doing, though, is healing the margin of the tissue, and the margin's often where a lot of the pain is.
Yeah.
So one of the ways I conceptualize that is, like, I remember a couple months ago, I cut my finger in the kitchen, and I had like a gash on the tip of my thumb, and the margin that was pretty painful. So I actually took out like a cuticle cutter and kind of trimmed that margin, so it was a cleaner margin, and it hurt a lot less.
Yeah.
And this is often like what orthopedic surgeons do when you ever hear about like an arthroscopic cleanup. They go into the joint, they use specialized tools, but they're basically trimming the margins to make the healthy margin at the edge of the tissue. So a lot of what you're trying to do with PRP is just to have a healthier margin of the labrum. And a lot of times that can be quite, helpful for improving pain.
Yeah. Yeah, I've seen really great success with PRP, stem cell, we'll just say orthobiologics, in like younger athletes. And when I say younger, like 25 to 50, I've just seen really great results with patients that have done that. And sometimes it's taken a couple of rounds,
Yeah.
but they have felt fantastic after.
Yeah, I think like it's, like every tool, I think if anyone has a stated success rate above 70%, they're probably lying either intentionally or not intentionally. I think a lot of times they lose track of their dropouts. So I think 70%, maybe getting into the 80% range, but like it's definitely not like a 99% success rate. Now the stem cell, stem cell is kind of we have to be careful. Like the Federal Trade Commission has actually gone after clinics for using stem cell because nobody's using isolated stem cell lines, nor would you not really want to. So to understand what a stem cell is a stem cell is a cell that has the potential to differentiate into something more specific. So the ultimate stem cell would be a fertilized egg, a man and a woman, they copulate, the sperm merges with the egg and then fertilizes the cell. From that one cell, an entire human being can grow. Now, you actually don't want anything that's too close to that state because, like, if I'm injecting something into the hip, I don't want it to turn into like an eyeball or hair or spleen. And that may sound ridiculous, but there's a type of tumor called a teratoma that you typically see in like an ovary or a testes. And you may have heard of like women who have like, a ovary the size of a grapefruit. They take it out and then you slice it open and there's literally like eyeballs and teeth in there. They're really kind of gross. And if you think about why does that happen, it's like, well, an egg cell is a cell that is capable of creating half a human being. So, when we're talking about stem cells in the context of musculoskeletal injury, we want something that's further down the differentiation cascade. And typically we're looking for what are called mesenchymal stem cells. And those are the cells that have the potential to differentiate into tendon or to muscle or to ligament or collagen.
Okay. Wow, that's fascinating. I did not know that.
Yeah.
Are there, you can say anything else about orthobiologics, but I'm curious if there's any circumstances that you're like, okay, we've exhausted this option. I think it's time for a surgical consult. Or are there any like with traumatic labral tears, are there any times that you're like, I think it's time for surgery? What is your thoughts on when to pass on to a surgeon?
That's a good question. I'm trying to think. Like there are definitely contexts and structures outside of the hip where I will go earlier. So like let's say in the knee, like somebody has a complete ACL tear. That's something where I'm going, like I can try to do these other things, but you're going to do better with surgery. And I'm pretty, frequently, I often have people who are seeing me for certain circumstances and I say, I can do this if you've already made up your mind not to do surgery. I'm willing to have that discussion, but you really should go to surgery.
Yeah.
For labral tears specifically, though, I guess like a situation like sometimes when someone has a labral tear, they could have something called a paralabral cyst.
Mhm.
So let's say I haven't seen this personally, but let's say you had an enormous cyst that was coming off of the labrum. Even if you had that, like the issue is like, is it impinging on another structure? And even there, most of the time, I would try to drain it first. So this is not an exact comparison, but I have like a patient, I've had a few patients. There's a smaller secondary knee joint called the proximal tib-fib joint. And sometimes those will be unstable and get big cysts and they'll hit a nerve called the fibular nerve. But even there, I just drain the cyst under ultrasound guidance rather than, having as a starting point to go right for surgery.
Yeah.
So, so I'm trying to think, is there a context, like if there was a huge cyst, just like where that's located, it's not going to necessarily impinge and like hit a structure where it's too far, it's not going to hit like the femoral nerve.
Yeah.
So I think for most people, especially also since the labral surgeries, like they're not awful, but they're not great either. I just think most people owe themselves the opportunity to try an orthobiologic first before they go to a surgery that's irreversible. The worst case scenario is the orthobiologic doesn't work.
Yeah. Yeah, I think I've only seen it a couple times where a patient has really early on considered surgery, and in both cases, they were really high level young athletes that were like about to go to college sports and just wanted their labrum repaired before they walked through that.
Yeah, I think that that's probably a mistake in most circumstances. And you probably have had this experience also. There is sometimes a tendency, so if you have like a continuum of aggressiveness, so like physical therapy, less aggressive than like needle-based procedures, it's less aggressive than surgery. There's sometimes a tendency to dismiss the less aggressive stuff. Yeah, it's kind of cute what you do. Let me get the real thing.
Yeah.
And I think that model doesn't apply for most musculoskeletal issues. I think it does for something, let's say like carpal tunnel syndrome. If you have severe carpal tunnel syndrome, the surgery has such a high success rate, has such a low complication rate. That's a circumstance where I think going and getting quote unquote the real thing and getting the surgery done makes sense. But with labral surgeries, again, like the success rates aren't that high. And I've definitely seen what you're describing, people getting ready for their college career, and then the surgery doesn't go well, and then they're some of them just never come back because I can think of a patient of mine who is themselves a physical therapist and had some surgery, and she's having some long-term issues, from, and I wouldn't even call it a botched surgery. I think it was just a surgery that just, it doesn't work because sometimes the surgery doesn't work.
Yeah, it's definitely not the end all. I
Yeah.
know. Do you have any considerations for clients that you have worked with that have the diagnosis of FAI or labral tear or both of them together? They're I won't put these words in your mouth, but they have that, and then they want to continue running and being active long term. Is there any secrets that you have about that?
Yeah, I mean, I guess I always want to know what people's goals are. So, in terms of running, for example, I always like to ask people, like, why are you exercising? Like, what is it that you're looking to get from it? Are you doing it for long-term cardiac prevention, overall health maintenance, for aesthetics? Are you doing it because it's your mechanism for stress mediation? Are you doing it for weight control? Are you doing it for diabetes control? And I think when I ask, I try to do it as much as a safe space because a lot of times aesthetics is part of it, but people are often leery to mention that that's why they're doing it. Because oftentimes, like, there's ways you can get them to meet their goal. But so, for example, like, let's say I have somebody who's running like 70 miles a week, maybe running 25 miles a week is an option for them, and that's part of what they can be considering. I think there are things like that, labral injuries will tend to be, I guess in general, running injuries tend to be worse when people have, large excursions of their motion. So a lot of people do better just by modifying their cadence, running a shorter stride length, higher cadence. So they're not taking the hip to that range of motion when they're grinding it as much. So, I mean, those are some of the things I'm thinking about. Yeah, but I think, if I'm having a runner, they've gone through good courses of physical therapy, they have done some modification in the running form, slumming persistent pain. Let's say they've already done a joint extension, really make a difference. That's where I might be thinking about the orthobiologics. Can I touch on the micronized fat a little bit? Because I didn't go into that fully. Yeah. So the idea behind micronized fat is, when people talk about stem cell, that's often what they're talking about, but it's probably about 1% stem cell and it has a bunch of other things in there. It is better than platelet-rich plasma. So I often tell people when they're asking about lipogems versus, which is the micronized fat product we use, versus PRP, it's kind of like the difference between a Lexus and a Toyota. Like a Lexus is definitely better than a Toyota, but oftentimes a Toyota is perfectly fine. A couple of the things I like better about lipogems, it has more healing factors in it, but also has more of a cushioning effect. It's also more viscous, so it tends to, like, if there's a crevice it has to get into, it tends to get in there and stick a little bit better. We've seen better, we're always kind of cautioned by like the FTC, like trying not to like claim cartilage regrowth, but I will say I've seen cases of cartilage regrowth with the lipogems. So like we've done pre and post imaging and seen it. So like it does have more regrowth potential.
So cool. So cool. Is it better to get those younger, or does age have an influence on that?
Yeah, in general, the younger you are, the better you are. One of the things I've learned over time is that we almost always do procedures at the wrong time. Is it okay if I elaborate on that? Okay. So an experience I had in 2019 is I got quite sick with pneumonia. I was sick enough that I missed a month of work. If I look back on that episode of pneumonia, had I known on day one that I had the sniffles, that was going to cause a bad case of pneumonia, I would have taken azithromycin right away. But I didn't do that because it's ridiculous to take azithromycin every time you have the sniffles. So we use time as a tool to determine whether you're going to do the intervention in the first place. But by doing so, you make things less efficacious. So I would say that's true for, physical therapy. You hurt your ankle. If you know on day one that day that you hurt your ankle, you're going to need physical therapy, the right time to go in is right now. But you often give it a week or give it 3 days and then like, okay, this isn't getting better, let me call Sarah. Similarly, if I know on day one that this labral injury is one that's destined to be getting lipogems, the time to do it is now, outside of other logistic factors. So doing earlier is better, both in terms of younger people do better than older people. Not that older people don't do well, but younger people do better. And then early in the injury is better than late in the injury.
Yeah, that totally makes sense. I like that point. Anything else that you want to touch on for women runners with hip pain? Any other thoughts?
Yeah, I think just a couple things about how to be a good patient. I think that's probably important. I think one of the things is we talked about, try as much as you can to separate data from your hypothesis. Often I'm dealing with like really bright people who've read a lot and they want to share what they think they figured out on their own. But like, I don't get a chance to unhear your story. So, if you're leading with what your suspicion is, it creates a discomfort because what happens if I disagree with you or I just want to consider another possibility? I don't want to offend you. And so I find like a lot of times when I look at people who've been misdiagnosed, it's because the patient came in with their own hypothesis and the physician didn't want to be aggressive in re-challenging that. So I think that's one thing.
Yeah, that's really good.
I think that, just as a doctor needs to create a safe space for a patient to feel comfortable talking, I think that a patient needs to create a safe space for their clinician to work. So, when you're dealing with female athletes, you want to look for things like relative energy deficit syndrome, sometimes called female athlete triad. So it's important that I can ask about things like eating disorders, talking about history of abuse that can be related. If you're having sexual dysfunction, that's something where that can be related to female pelvic floor. So if I'm talking to a patient and they're guarded on, just basic things, like if I'm just, trying to get their demographics and they're very guarded and talking about their relationship status, they're not comfortable talking about who lives with them at home, I'm not going to get into their sexual history, so creating a safe space where the doctor can evaluate them. Similarly, allowing the doctor to examine the area that hurts. So you would be surprised by how many patients do not want the doctor to look at the area that hurts. And, I get that, it's a sensitive area and you want to be discreet in the hip region. On the other hand, if the doctor can't actually look at the area that hurts, it makes it harder for them to do a good job evaluating them.
Yeah, that's really fair.
Yeah.
Yeah, I really like those points about not coming in with the hypothesis, because if there's, something going on, let's say it's really driven by the back, and then that's the diagnosis and that's the exercises that we're going to do, or that's where the treatment's going to go. You as a patient are probably not going to believe that you're going to get better because it's not, you believe it's coming from your hip.
Right.
Yes. Well, I think that's all I have for us today. Thank you so much for coming on. I learned so much from you. If we want to get in contact with you, either local or just want to learn more from you, what are the best ways to do that?
Sure. I mean, there's our website, which is www.lakewass.com. We have a YouTube channel. So if you put in Gary Chimes, Lake Wass, we have a bunch of videos, with some videos on lipogems, about PRP, about tendon injuries. So those are probably the best resources to look for us.
Okay, awesome. So I will be sure to link those in the show notes. But other than that, thank you so much for coming on. And I look forward to chatting with you soon.
Okay, great. It was great talking to you.